Welcome back. In this video, we are going to dive deep into the specific clinical features, investigations, and diagnostic criteria for neuromyelitis optica, or NMO. Because NMO shares several overlapping features with multiple sclerosis, or MS, we will be constantly comparing the two to highlight the distinct characteristics that help us arrive at the correct diagnosis. Now, this summary frame includes all of the key concepts we're going to cover, but don't worry, we'll break everything down step by step, and we will bring this slide back up at the very end of the video for a quick review. Let's start by looking at the clinical features, specifically focusing on optic neuritis. In NMO, the severity of vision loss is typically quite severe. This stands in contrast to MS, where the vision loss is generally milder. Another key differentiator is bilaterality. While optic neuritis in MS is usually unilateral, affecting just one eye, in NMO it can often be bilateral, affecting both eyes at the same time. Furthermore, when we look at the extent of the inflammation, longitudinal extension along the nerve is common in MMO, whereas it is less common in MS. Next, let's move down to the spinal cord to discuss myelitis. A hallmark sign to watch out for in NMO is longitudinally extensive transverse myelitis, or LETM. This is defined as a lesion that extends over 3 or more contiguous vertebral segments. In MS, the lesions are usually smaller, spanning fewer than 3 segments. Additionally, when we examine the axial MRI sequences to look at the cross-section of the spinal cord, a distinct pattern emerges. In NMO, the inflammation is characteristically centered right in the middle, targeting the central gray matter, or majority of the cord's cross-sectional area. This is a major difference from MS, where the lesions tend to be located on the outer edges within the peripheral white matter. Now, historically, it was thought that the brain was spared in NMO and generally appeared normal. However, it is now recognized that brain lesions are present in many cases. These lesions are described as large and cloud-like. Crucially, unlike the lesions in MS, these cloud-like lesions in NMO are often asymptomatic, non-destructive, and can sometimes resolve completely over time. The symptoms depend heavily on the region involved. For example, lesions in the area postrema can manifest clinically as intractable hiccups or vomiting. On an MRI, this appears as a hyperintense lesion in the lower medulla with enhancement. If the hypothalamus is involved, the patient might present with sleep disorders or endocrinopathy due to diencephalic lesions. When the cerebral hemispheres are involved, patients may experience focal symptoms, encephalopathy, or seizures. When examining the optic nerve, we specifically look for a T2 hyperintense lesion or an area showing T1 gadolinium enhancement. What makes this distinct is the extent of the damage, as the lesion typically stretches more than half the length of the optic nerve or involves the optic chiasm. This stands in contrast to multiple sclerosis, which is characterized by Dawson fingers. These are ovoid lesions appearing perpendicular to the lateral ventricles, typically following the path of the deep medullary veins. Additionally, MS scans often reveal T1 hypointense lesions, known as black holes, which indicate areas of permanent axonal damage and tissue destruction. Finally, let's discuss the investigations involving cerebrospinal fluid, or CSF findings. In NMO, pleocytosis, which is an increased cell count, is generally greater than what is seen in MS. When we look at the specific cell types, acute NMO cases show the presence of neutrophils and eosinophils, whereas in MS, lymphocytes predominate. As you can see on the left, oligoclonal bands are actually rare in NMO patients, appearing in less than 20% of cases. In contrast, the presence of OCBs is considered a hallmark of MS. They're found in the vast majority of MS patients, specifically in more than 80% of cases. Therefore, finding these bands strongly supports an MS diagnosis, while their absence is much more consistent with NMO. Now, let's look at the molecular signature during an acute attack. When we analyze specific protein markers, we see markedly different levels that reflect the distinct underlying inflammatory cascades in these diseases. If you look at the graph, we are focusing on two key markers, interleukin-6, or IL-6, and glial fibrillary acid factor, known as GFA. In NMO, represented by the blue bars, we see that during an acute attack, both IL-6 and GFA are markedly elevated. The high level of GFA is particularly significant because it indicates substantial damage to astrocytes, which are the primary targets in NMO. In contrast, if we look at multiple sclerosis, shown in orange, the levels of both IL-6 and GFA are significantly less elevated compared to NMO. This difference in biomarker elevation provides another layer of evidence to help us distinguish between an acute NMO attack and an MS flare. All right, as a quick recap, NMO is defined by severe, often bilateral optic neuritis and longitudinally extensive transverse myelitis that centers on the gray matter. Investigations reveal unique MRI signatures like cloud-like brain lesions and long optic nerve enhancements, while CSF analysis helps rule out MS by the absence of oligoclonal bands and the presence of neutrophils or eosinophils during attacks. Now, let's turn our attention to the official diagnostic criteria for neuromyelitis optica, which is based on the guidelines established by the 2015 International Panel for NMO Diagnosis, or the IPND. The diagnostic criteria for neuromyelitis optica spectrum disorder, or NMOSD, are divided into two main categories based on the patient's serological status. Specifically, whether they test positive or negative for the AQ4 antibody. Before we look at the criteria for patients who are negative for the antibody, let's define what those core clinical characteristics actually are. There are 6 specific clinical presentations recognized in the guidelines. Number 1 is optic neuritis. Number 2 is acute myelitis. Number 3 is area postrema syndrome, which is characterized by unexplained hiccups, nausea, or vomiting. Number 4 is acute brainstem syndrome. Number 5 involves symptomatic narcolepsy or acute diencephalic syndrome, provided there are typical NMOSD lesions on MRI. And finally, number 6 is a symptomatic cerebral syndrome with typical brain lesions. Now, let's start with the first scenario, NMOSD with AQ4 IgG positive status. This path is a bit more straightforward. To make the diagnosis here, you need 3 elements. First, the patient must present with at least one core clinical characteristic. Second, they must have a positive test for AQ4 IgG, and it is strongly recommended to use a cell-based assay for this to ensure accuracy. And third, you must reasonably exclude alternative diagnoses. Now, let's look at the second scenario, NMOSD without AQ4 IgG, or where the status is unknown. Because we lack the specific antibody marker, the clinical bar for diagnosis is set higher to ensure we don't misdiagnose the patient. In this group, the patient must exhibit at least 2 core characteristics. But it's not just any 2, there are strict requirements. At least one of the 2 must be one of the big 3, either optic neuritis, acute myelitis with longitudinally extensive transverse myelitis, or LETM, or area postrema syndrome. Additionally, there must be dissemination in space, meaning 2 or more different clinical characteristics must be present. Just like the first group, the AQ4 test must be negative or unavailable, and alternative diagnoses must be excluded. Furthermore, for these seronegative patients, the clinical findings must be supported by specific MRI requirements. If the patient has acute optic neuritis, the brain MRI should be normal or show only nonspecific white matter lesions, or the optic nerve lesion must extend more than half the length of the nerve or involve the optic chiasm. If the presentation is acute myelitis, the MRI must show that characteristic intramedullary lesion spanning 3 or more contiguous segments, our classic LETM sign, or focal spinal cord atrophy of the same length if there is a compatible history. For area postrema syndrome, we need to see lesions specifically in the dorsal medulla or area postrema. And for acute brainstem syndrome, the MRI requires perieppendymal brainstem lesions. Here is a summary of the diagnostic criteria that we have just reviewed. Essentially, if the antibody is present, one clinical sign is enough. If the antibody is absent, we need 2 clinical signs plus specific MRI evidence to confirm the diagnosis. All right, as promised, here is that summary frame again, and you can also download this from the video description below. We are just starting this channel, so your recommendations on how to improve future lectures will be highly appreciated. If you found this helpful, please subscribe and hit the notification bell. In the next part, please leave your suggestions and questions in the comments. Thanks for watching.